Hello, everybody. I'd like to welcome you to the Resident Family Support Council meeting. Just to give everybody a little bit of a reminder about what this meeting is all about, we conduct this meeting to empower people with that live in long-term care or have somebody that they love in long-term care with information so that you can get what you need, want, and deserve. It looks like I have my video going, but unfortunately, I am not showing up on this. I don't know what's happening. So today, I guess you don't get to see my lovely face. Today, our topic for today is you can be treated for COVID and understanding the various treatments and when and how these are administered. We have Dr. Barnes joining us today. And I'm going to turn it over to her in a minute. But before I do that, I do want to remind some people that we do ask that you can put your, if you could put your zip code into the chat, along with how many people that you might have watching this with you. That would be great. That's how we track to see where people in the state are participating in this. And then also, I also want to let everybody be aware of that we do have these videos. We do record these videos, and I did make sure that I got it recorded today because I did not get it recorded last meeting, which I apologize for. But we are recording them, and then they go on the YouTube channel, and it's the Illinois Ombudsman YouTube channel that you can access to see all of our past meetings. And then also, as the opening slide showed, we also do have our Facebook page, which we'd love for you to get on and make sure that you like that page. Also, that's another direct link to be able to get into these meetings. It always goes up the day of the meeting. You can always get onto Facebook, and the link for the meeting is right there. So you can share that with families and friends. And today's topic is one of those topics that personally I did share with some families and friends as well, because this topic is important, not just for those that live in long-term care facilities, but really everybody. And that's why when we spoke with Dr. Barnes about this, was really intrigued with how people just are not aware of the various treatment options. And this is really empowering information for everybody. And I think it's important to know this information before you wound up, if you have somebody that you love gets COVID. So Dr. Barnes, if you would like to, do you have any slides that you wanted to share with us today?
Yeah, and I'll share my screen here.
Perfect. Welcome, Dr. Barnes.
Yeah, welcome. Thank you, everyone, for taking the time. And I just want to introduce two, or I don't know who else is from our fantastic team, Dr. Cunard and Mary Alice Lavin. I saw their names, but I just want to say they're part of our team that does extremely dedicated work with our long-term care facilities. And I just wanted to highlight some of the challenges that we've been having with getting our long-term care residents treatment for COVID. Now, can everyone see the screen okay, or are you seeing notes page or a full presenter view?
We've got it. It looks perfect.
Okay, great. All right. So the first thing what's going on with COVID treatment? So we have right now 2 pills and 2 IV intravenous or in the vein medications. And these 2 pills have been out since January. I was just on a call with some providers, and one of them was like, "Oh, is this pill still out?" And I'm like, "Yes, it's been out for the past 6 months and available to use." So and I'm going to go into the details of what do you need to know about these 2 pills. The 2 IV forms, one of them is called Veklury or remdesivir. We've used it inpatient, and now we can use it outpatient to treat people with COVID. And the other one is called bebtelovimab. It's a monoclonal antibody. Now, the 2 pills and bebtelovimab are the ones that are offered free through the US government through the states. Veklury or remdesivir is not. It's a little different in terms of how it's used. You need to get an IV. You get the IV over an hour every single day for 3 days. And that can be challenging. But it works really well. And if it that's the option for a long-term care resident, it's a really valid option. Bebtelovimab is just a one-time IV. You just give it once, you just push it in the vein and you're done. And the pills, I'll go into more details about that. When we think about where is this available, the good news is that there are lots of pharmacies and facilities all across Illinois where this is available. Treatments are available, including long-term care pharmacies. And that I'm going to go into that in a second. So if you just look at a locator, if you're worried about where is your loved one, and they may not always be residents in a nursing home, they may be in an assisted living facility, and they do use retail pharmacies. And if their doctor doesn't or provider doesn't know where to send the prescription to, you just help them out, there's a little magnifying glass, put your zip code in there, and it'll pop out all the different locations close to where you are that have the drug and the different drugs. And that can, again, you can use that to advocate even on their behalf. So just most of these locations are pharmacies. You could see for the oral pills, it's mostly pharmacies. For the monoclonals, because it's an IV medication, it's a good split between clinic hospitals and clinical practices. Now, not a lot of congregate care pharmacies have these, but about, again, 13 congregate care locations have oral medications as well as monoclonals. To the right, you'll see a map of what's called the long-term care pharmacy program. So through the federal government, long-term care pharmacies can request a direct allocation of these pills and these medications. It doesn't have to come out from the state's allocation. And there are about 54 locations that have these that have signed up, I should say, as a long-term care pharmacy participant, for this program participant. So let's talk a little bit about these two pills, right? Now, people think, okay, it's just a pill, but the challenge is it's not just one pill. Now, they work well. So Paxlovid is excellent. It can decrease your chances of getting to the hospital or or even dying from COVID, almost 80–90%. And that is important because you need to treat only 18 people to save one life, one hospitalization with Paxlovid. But it's 3 pills in the morning and 3 pills at night. And these pills cannot be crushed. So for those, especially our elderly who might have a feeding tube or might have feeding difficulties, that's sometimes not an easy thing to think through. And this is a pill that can interact with a lot of other medications. So it requires a lot of care by the pharmacist, by the doctor, by the provider to be able to say, okay, this is safe for you. Yes, you're on cholesterol medication. Let's adjust the cholesterol medication so you can take this because this can really save their life as far as COVID is concerned. The other one is molnupiravir. Molnupiravir doesn't have any interactions with other medications. It doesn't work as well. It's about 10–30% effective in preventing hospitalization or death. And so it's considered an alternative. Like if you cannot get Paxlovid, molnupiravir is your option. 4 pills in the morning, 4 pills in the evening. So 8 pills, 8 more pills a day. But again, you take it, it's only, again, a 5-day course of treatment. So you're not taking these pills forever. You're not taking them for a month, but they're, and you cannot crush them. So this is the important thing. The other challenge is getting people in early to start treatment. I get this question a lot. They're not sick enough to need treatment. But that is a huge misunderstanding in our provider community, that you need to be sick enough to need treatment. In fact, these medications work when you're not sick enough to need hospitalization. If you're really sick, you need oxygen till the point that you need to be in the hospital. There are different medications that work for you. This is to prevent you from going to the hospital. And that means you have to treat it early. Within 5 days of you starting to get sick, you need to get these pills inside you. So the timing is important. And it's, again, There's no such thing as, oh, they're not sick enough to need treatment. You do have to have a little bit of symptoms, like maybe a sore throat, maybe a runny nose. But if you wait till you're too sick, then these medications are not going to work. So for Paxlovid, you have to think a little bit about your kidney. The good news is that even if your kidney function is a little off, they have a lower dose that you can use for it. Liver function too, if you have very severe liver failure, this may not be a choice for you. And that's part of the reason why for a lot of our elderly, the monoclonal antibody, that one-time IV push of the medication because of feeding difficulties, because all of that becomes really a very viable option for treatment for COVID. All right, so these, as I said, you need to remember that part of it. So when we try to see, okay, how much are long-term care residents using or how much our facilities using treatment? Now, this is just this wave in April when we just started becoming a little, going from, low to medium to high community levels. These were some of the early counties that went into high community, like medium community levels. And we're like, let's look and see what's going on with treatment. And just these 14 counties, we noticed, constituted a lot of the cases, about 70% of the cases in long-term care residents. There were about 100 hospitalizations that occurred and across the state. And unfortunately, people died even in this last little wave, though a lot of people didn't care. No one put their mask back on. No one was concerned about getting tested before they visited their loved one. There were people who unfortunately didn't make it. And when we look to see how much did the facilities in those areas, and it's not one specifically, just report use, in Illinois, only about 130 courses of treatment were used out of 1,300 people residents. So it's about 10% of the long-term care residents who needed treatment or could have needed treatment got treatment. So we need to break that barrier. We need to get to the messages. Part of it I heard, sometimes the patients are hesitant to get treatment because they're like, oh, I'm not feeling so bad. Why should I get this treatment? Sometimes the providers are hesitant. Sometimes the family members who are the decision makers for the patients don't know enough about the treatment, and they're worried to put their loved ones, subject them to a treatment that they don't know much about. And there are multiple factors, but these medications, especially, as I said, Paxlovid, we know it works really well in keeping people out of the hospital and saving lives. And that's something we need to, help improve in terms of our use. So what did we do? We tried to do a little pilot, seeing how can we get maybe one or two facilities treatment very fast, as soon as they turn positive for COVID, like within a day or two. And we know that there's a lot of testing that occurs at facilities every single week. And again, we know the challenges to all the drugs, including the monoclonals. There's a cost attached to getting an IV medication as opposed to just taking the pills. And so when we started doing that, the good news is we found some really good information. Out of the 184 people who got treated according to this, most of them got the monoclonal antibody. There were only 3 hospitalizations. So that's a less than 1% hospitalization rate, and no deaths so far. And that's very reassuring. Our data is not complete yet, and we'll definitely want to share more about this soon. But this is, again, very reassuring to know that the medications are working. In general, this long-term care residents have a 10% chance of getting to the hospital once they have COVID. And to see that this is less than 1%, 3 out of 184, that's numbers right there. You don't have to believe the research. You don't have to believe anything. You just know that people who got this, very few of them, much fewer of them ended up in the hospital than those who didn't get any treatment. So we asked providers, we sent a message to providers saying, because some long-term care facilities don't have a pharmacist on site to help go through all the drug interactions. The pharmacist might come once a week, the medical provider might come once a week. And so are there for services providers who can go to someone's home, go to a long-term care facility across the state, go to a homeless shelter, correctional institution, and give these treatments, assess the patient for it. And the good news is there were about 34 providers who responded that they could. About 8 of them said they could go statewide, but a bunch of them said, okay, they'll be able to service one specific region or the other. And as you can see, at least about 23 said they could go to a long-term care facility. And we're trying to do that. We're trying to get the concept of what we call strike teams to go in and give treatments, but people are getting infected today as we speak. By the time we get all of this set up, we don't want another life to be lost. We don't want another person to end up in the hospital. And so it's really important that we can try to advocate as consumers for this now. And we did a little bit of a consumer survey, and this just launched a week ago, and we only have a few responses, but to find out, what are people who actually are trying to seek treatment? What is their experience like? And it turns out, a lot of them thankfully go to their primary care provider, but about 20% went to an hospital or urgent care. Now, this may not apply to someone who's, say, in a nursing home, but it certainly could apply to someone who's in IDL or an assisted living facility. And that needs to, we need to make sure people can get the care they need, even if it's where they're at. Especially we want to increase the rates of the telemedicine visits. And then we say, strangely, a lot of people didn't know what treatment they were prescribed. About 43% said we don't know. Again, the numbers are still small, but this is where the interesting part, we wanted to, did you have a hard time getting an appointment? Thankfully, most people didn't. People did start having more difficulty getting their prescription filled. And a lot of people who needed to get the IV medication had look at that, 57% had difficulty getting their IV medication. And there's a cost attached to it. It's about $350 if your insurance, that will be claimed on your insurance. If you get it at home, it's about $550. And so we don't know if that's something that's a barrier. We asked our providers hesitant, and look at that, about 30%, 29% said the providers were hesitant to give them treatment. And a lot of people were, of course, not a lot of people were individually hesitant. A lot of people said, yeah, no, we would get treatment. So is it more the provider than the patient? You look at that split here. And that's why we need to get education to the providers. We've been trying every which way for a long time, and we realize that it has to come through the patients too. And again, people feel like they are aware of the therapeutics, so that's good news. Here are some of the comments that people left on the survey. Some of it was really heartbreaking for me. I mean, it said, my provider would not prescribe therapeutic, was saving it for hospitalized patients, even though have several qualifying conditions. This was an 87-year-old person who wasn't in a resident, but it could easily happen to a long-term care resident with COPD. It's a lung condition, who went to the ER and was told that he was not sick enough, again, to be in the hospital, and was not sick enough to need treatment. Again, we need to get shape. And this poor man thankfully had a very passionate daughter who called and finally got treatment. He finally got treatment. It should not be so hard to get treatment. This person who says they were charged money even though they had insurance, they didn't realize insurance would not cover the cost of the monoclonal. Now, the drug itself is free. The drug is about $2,000, and that's free. But to administer it, to get the IV, the administration fee is about $350 to $550. And that can be a challenge. Now, it looks like one person thankfully had a good experience. Their doctor adjusted the cardiac as heart medications. One person said they did not did not get the medication. And this person says they were 68 years old, called 3 days in a row to their primary care provider, went to the ER, had to go to the ER to seek medication. And again, this last person, the doctor called in an antibiotic. So if they were COVID positive, this is not the medication they really need. It's they said this is not something they should get. And what we do want, I'm going to put the link to this consumer survey in the chat. I just want to again thank the Department of Aging, everyone, the Ombudsman program for trying to advocate for this, and also our team, Dr. Kunarna and our therapeutics program manager. I'm going to put the survey link. Please share this. Please, if you have any COVID experiences, have your family, whoever, report on that link. Once we realized that we needed to be able to reach out to people who are leaving those comments, we put a little box in there saying, if you want us to reach out to you, please let us know so we can get more details about what's happening. And we try our best, like if we hear there's a specific hospital that someone went to the emergency room, wasn't offered it, we've in the past called the chief medical officer of the hospital and says, hey, what's happening? Why are your providers not offering treatment? So we'll be happy to do what we can. And I'm going to put the link in the survey. So I just want to say thank you. I have a hard stop. I have to leave at 3:30, but we have, again, Dr. Cunard, Mary Alice. I don't know if anyone else is on the team who can also help address some of the questions that come up today. Thank you.
Thank you, Dr. Barnes. Really appreciate it. And I do want to let everybody know, you had shared some flyers with us previous to this meeting. And so they are going to be posted on our website. On two sites, on two locations on our site, one with our Resident and Family Support Council materials. And then also, we also do have a COVID link on the Ombudsman page as well. So they're going to be there. So know, everybody, that this is something too that you would be able to forward on to anybody that you know and love to help give them better indications. And these flyers are really nice because they do talk about some of the interaction, some of the things, that you may need to, like with the kidney, if you have kidney issues and things like that. They do talk about those things. So they're very informative. So I want to say thank you for sharing those with us, and that'll be a great resource for people moving forward. We did have somebody that did want to share their experience that had COVID. Carrie is one of our family work group members for this group for our Resident and Family Support Council, and she's also highly involved with Caregivers for Compromise. And Carrie unfortunately got COVID a couple of weeks ago, and she is an advocate. So what did you do, Carrie?
So I guess I'm very lucky to begin with because of having so much experience with IDPH and the COVID team, who has been wonderful through all this. I knew what the antibodies were. I knew what I needed. So even like when my son got COVID in February, I was on the phone immediately trying to find out. Now my son couldn't take them because of his risk factors. But when I called literally 2 hours after I tested positive and I started showing symptoms the night before, I called tested next morning, called immediately on a Sunday morning. And the on-call physician for my family practitioner's office was like, yeah, there's no way I'm not giving them to you. He said, but the advantage was, he's like, because you're educated, you knew what you were asking for, you knew what to tell me, and I have a heart condition, all the rest. So it was imperative for me to get them to keep me out of the hospital. And I still wound up somewhat sick, but I didn't need the hospital. And I didn't wind up, getting in trouble in any way, shape, or form. My husband wound up testing positive a few days later. And at first our family doctor's like, well, he's a little healthier, we're not going to give him to him. And 2 days later, I'm like, yeah, no. And I made him call again. And then he went on him, and within 36 hours of him getting him, boom, the whole thing. So they really do work. Both the doctor and the pharmacist made sure to ask me the questions of, are you taking this? Okay, you cannot take your 2 cholesterol medicines until you are done with the antibodies because they don't mix. The same reason when I was told my son isn't eligible, it's because they don't mix with anticonvulsants, which are seizure meds. So it's, it's being proactive enough to ask And thank God, you know, like I said, because I've worked with IDPH so much over the last 2 years, that there are times that I think I'm educating facilities and stuff because they haven't been on all those calls that I spend hours and hours driving all these wonderful people crazy. So,
Carrie, yes, thank you for sharing that, because I had an experience with my mother. And again, I have to say it's because I was told, I was given information. By attending the Illinois Department of Public Health's Friday meetings that were being conducted. My mother, 89 years old, had COVID, and she had a tumor in her lung years ago, so she's missing half of her lung. So of course we were very worried, and I got her in within that 24-hour period of getting diagnosed, and she had the monoclonal antibody. She had that done, and I'm really pushed for that to happen for her. And I have to tell you, my mother really didn't experience anything. She did extremely, extremely well. So this was a moment of all of us being very fearful. And so now my mother is one of the biggest proponents, and she's shouting from the rooftops, telling everybody, you need to listen. You need to know, you need to be educated. And that's what these meetings are about. So that's what we appreciate. And I know that I do recognize that you need to leave here very soon. So I don't know if anyone else can help. I have some questions myself, and please, people, put questions into the chat so that we can address those questions, concerns, any of those. But I know one of the questions that pops into my mind is, why is this not being offered to residents standardly when they have COVID in the nursing homes?
Yeah, and that's something we're trying to work on. We try to have our medical directors of the nursing home step in, but there's such a diverse group. We couldn't get a lot to attend some of those sessions. So I think, unfortunately, I'll have Dr. Cunard and Mary Alice also talk about some of our efforts to try to get nursing homes to just keep some available, because I know if they just have them on hand, they'll be able to give them to their patients. So where anything we can do here through the ombudsman program, through the advocacy groups to leverage with nursing homes and the importance of keeping this, we need to do that.
So do they have a shelf? But you have to leave now. So I don't know.
Sorry.
If Dr.
But
Cunard,
Dr. Cunard is here, yeah.
Okay, great. Dr. Cunard, I don't know if you could help answer some of these questions.
I'll try.
Great, thank you. Do they have a shelf life on them? You know, so they can have them on hand? Is that what I was hearing Dr. Barnes saying?
Yes, they do. I believe that it's 15 months. I can verify how long that is, but yes, they do. They, like any medication, they will have an expiration date. Yes.
Okay. So that's not the barrier. That's not the reason that long-term care facilities are not having these available for treatment options. Do you really feel it's just more of this, we don't know what we don't know sort of a piece?
Right. Yes, I do think that it's a lack of familiarity and then concern. You know, historically, we know that it takes many years for new therapies and recommendations to percolate through the entire medical community. But we don't really have time to have those processes. So we've been doing a lot of meetings. We've mentioned the therapeutics multiple times on both. We meet, Dr. Barnes and I meet regularly with all the pharmacy leaders in the state for both the long-term care pharmacies and for Walgreens and so forth. Therapeutics and vaccinations have been our topics of conversation. We meet with all the long-term care facilities. As you know, we have the weekly, it was weekly, now it's every other week on Friday, and therapeutics again has been a topic to say if someone becomes positive, regardless of whether they were vaccinated previously and so forth, they need to be evaluated for therapeutics in this population, and then meeting with any doctor groups that we can think of to help get that word out. Also, the local health departments, meeting with all the local health departments, because long-term care facilities are required to notify their local health department when they have cases in their facility. And then the local health departments are to ask, please, are you thinking about therapeutics?
Well, that's
But not just one time either, you know, as soon as the person is positive, maybe they don't have symptoms, but they might get them a couple of days later. And so doing that careful assessment. We have our infection preventionists. I know Karen Trimberger and Mary Alice Lavin are on the call. I don't know if you have anything else. We have infection preventionists. We have 8 who are assigned across the state, 4 who are really working exclusively on COVID-19. Mary Alice and Karen are 2 of them. And they work with local health departments and long-term care facilities as well, and are bringing up the possibility of offering therapy too. Did Karen or Mary Alice, did you have anything you wanted to add?
Hey, Dr. Kennard, this is Carrie Laldridge. I actually have an idea. What if getting the local health departments, since they know who the facilities are, they know who the medical directors are, you know, like us, we're in a small rural county. And, you know, when my son got it, the first comments, the facility said to me, hey, will you reach out to his specialists and ask? They're like, because the medical director is not comfortable even debating whether he is eligible.
Yes.
So I think that's where some of that breakdown goes down, that the facility knows about it, but they don't have the right people to be comfortable making that decision.
Right. You're absolutely right. And so we're trying to get this from every angle. The pharmacies that give the treatment, the medical directors, as Dr. Barnes said, we've reached out to different physician groups, Illinois Academy of Family Physicians, you know, the types of physicians that often serve as medical directors. There's a medical director professional organization in Illinois and so on. So we've reached out with the pharmacies, the long-term care facilities, the local health departments. We were super excited to be invited to come and speak to all of you as well. So the ombudsman can even be, and family members can even be advocates asking about the therapy. And anytime anyone is uncomfortable, we've talked to lots of medical directors, and I shouldn't say lots, but to many medical directors, and just walked through different ways, you know, and I've given large presentations to our sister state agencies, for example, to all the medical directors in their facilities to make sure that everyone is thinking about it and evaluating individuals for administration of therapeutics.
This is Karen. I was just going to add one quick thing. As far as making sure when we're looking and investigating outbreaks at long-term care facilities and having discussions with those facilities, we're asking if the residents have received therapeutics or not. And if they haven't, or if it's not even been thought of, although I have to say they're improving as far as considering it now than what they used to. But Dr. Kennard and Dr. Barnes have been gracious enough to, if we get the medical director's phone number, they will talk directly with that medical director at the facility to facilitate the therapeutics being ordered for those residents. So kind of on the back end, mind you, but we're still trying to attack it from several different approaches so that we can get the meds to the residents as needed. And Mary Alice may have something else to say too. I don't know.
No, just in general that we are trying to provide the information as much as possible when we reach out to the facilities. And there is some misunderstanding still about the fact that the therapeutics can be offered to residents even if they don't require hospitalization. So we just try to give them all the resources possible to make a good decision.
Yeah, because it seemed, I mean, if I heard the statistic right, only 10% of those who needed the treatment have gotten the treatment. I believe that was on a slide that Dr. Barnes mentioned that. So if I am, let's say I live in a long-term care facility and I get diagnosed with COVID and I say, hey, I know there's treatments out there. I'm not quite sure what they are, but I know I've heard about this. And I say this to my nurse, and the nurse is like, I can't help you with that. We can't give you that. We're not allowed to. And that's what they may say. We're not allowed to give you that. What would be your response to that? How should I respond as that resident to the facility?
Well, those have been some of the conversations that we have had, and that's when we'll get the medical director's phone number and Dr. Kennard or Dr. Barnes. Primarily, probably Dr. Barnes has had those one-on-one conversations with that medical director, that physician, or that resident's physician to encourage, educate that person about the benefits of providing treatment to that resident. One-on-one conversations, again,
Right.
that's taking it down to the lowest level, right? But if that's what it takes, they have been willing to do that, to able to maybe, get the drug where it needs to be.
So if I, as that resident, I could say, well, I know there's drugs out there. I'm not quite sure what they are. Perhaps maybe they could even go to our website. We do have that flyer readily available. Say, these are them. And please speak to my doctor. And if my doctor won't order it, then I'm going to connect the medical director here to make sure that happens, because I want to get this. Would you advocate for, at the resident level, doing it like that?
Sure, I think it's good. Sorry, for some reason, my computer disconnected there for a minute, but I'm back. This is Dr. Kennard again. Yes, that's one reason why we're asking. I think if families are asking about it, or residents, if they're able to ask, that would be very helpful as well. And it also would be helpful to get the information out. So if the doctor calls or makes the recommendation, then the families will say, oh, yes, I agree to that. And they're not concerned.
So it almost feels that everybody that's on this call today, and there's 66 people that are currently on this call today. If the message that we could say is get that flyer, bring it to the long-term care facility that you're affiliated with, whether you live there, work there, or have somebody you love. And because while you're going through it, you need to act quickly, correct?
Yes, the pills have to be given within 5 days of either a positive test or symptom onset, the diagnosis. So if somebody's got symptoms and then they're tested and then we find out that they have COVID, or it could be that maybe there's an outbreak at the facility. And so the resident was tested, and at the time they were tested, they felt fine, but they had a positive test. But so within 5 days, either of when they first had symptoms and they were first diagnosed. So I guess it's within 5 days of diagnosis is when it should be given the pills. But you have 7 days for the IV monoclonal antibodies. I think another barrier has been getting IVs into facilities because they may or may not give IV medications at the facility. So just having that comfort level and knowing who, really we're asking facilities to know who in their area, where they can get it, either through their own long-term care facility, their provider, other pharmacy provider, and make those identifications. So that's another thing family members could do before their family member was even ill, and maybe they never will become, but at least be proactive and say to the facility, have you thought about if you have an outbreak or if my loved one gets COVID, how you're going to get this treatment to them in a timely way? Could be helpful.
Dr. Kennard, I'm going to add something that most people probably don't know. Not all facilities, even though they are skilled nursing, does not mean they're licensed for IV care. So just for people to understand, it's part of those reasons are based off of how their license is. So you need to know those answers to be able to get the question.
And then there's always the pill option, or also, there's nothing to say you couldn't take your loved one out to get the IV treatment. I brought my mother to a clinic for that to happen for her when she had that that was back in December when she had that. So we were very proactive in trying to do that. And I guess that's really the message here, everybody, is that it's up to us. We can't depend upon the facility to say, oh, you have COVID. These are your treatment options, like it would be if you had something else. This is new. This is new to everybody. And so because this is something that people have, the facilities have not gone through before. It's up to those who live and have somebody that they love that live in these facilities to be that change maker and to be that motivator. And I liked what Dr. Kennard said regarding doing it, being proactive even before, finding out that information prior to. Again, I was lucky. I had put in my back pocket when knowing that my mother potentially may someday get sick. And I had put it in my back pocket knowing that there was a clinic that she could get that at. And again, I got that information through the Friday calls. So that's why we need the Friday calls that IDPH was doing with the long-term care facilities. So I think that that's really important for people to do that and to not accept that answer of no. The facility does have the responsibility to care for you. And that care includes that taking your request, and if you want to be treated, to be able to get treated, and to make sure that you are spreading that word to everybody else that lives in that facility as well. And my thing is that I can see happening across the long-term care world is because it's that situation of we don't know what we don't know. Somebody gets COVID, they say, what can you do about it? And the facility is like, well, there's really not much that we can do, because about a year ago, there wasn't much that they could do. But now we've advanced so much that we have options, not even just one. We've got, is it 2 pills and then the IV treatment? Is that correct?
Yes, that's right.
So we've got 3 options now that we could be pursuing, and it's up to us to speak up and say, I want it and I need it. And if you can't give me the IV treatment, help me find a resource for that, or get me the pills so that I can take this. And if Carrie shared that she was on a cholesterol medication and it doesn't react well with that, so she forewent taking that cholesterol medication for those 5 days, because it's only 5-day pill treatment, so she was able to go off of that medication to be able to take the other medication so her COVID could be treated. Has anybody on the call, I'm very curious, has anybody else on the call been proactive and had that treatment? Is there anybody? If there is, please unmute your line so that you could share with us how that experience went for you. Because we have not heard from any family members saying that the facility isn't getting the treatment for me. This is still new for us. I want every ombudsman on the call too to be aware of this and to make sure that if we're visiting the facilities and there's COVID facilities, people, they're inactive COVID, that also we can start asking the facilities about this as well as ombudsman. And there are those flyers that are on our website that you should be able to get, and you can pass those out as well to the facilities to help encourage them to explore these treatment options and make sure that they're treating their people. This mention about the cost, if that could be reviewed again, I was a little confused on that. Does Medicare and Medicaid cover the cost for these treatments?
I don't recall that detail. Do you recall, Karen? Or Mary Alice? I think Dr. Barnes is more up on that. We can get back to you on that. We have heard that individuals might be charged an administration fee for the IV if they're taken somewhere. Not for the, but just the charge for getting an IV, because the staff have to be paid. If they don't have insurance, that covers it. But whether Medicare and Medicaid cover it, I'm not sure about that. Do you know?
Yeah, I mean, I've heard Dr. Barnes say that the medication itself is free, but like you just mentioned, the administration, so the IV component of it is not covered. So there would be a charge for that service. But the medication should be free of cost.
So the pills
paid by the federal government, obviously, but
would the pills be taken care of by Medicare and Medicaid?
Well, that was my understanding.
Pills
But-
are
but
free,
we
right
can
now to
clarify.
everyone. The
Yeah. we'll
only place
clarify.
where there might be a charge would be the IV administration fee to pay the staff who are giving the IV. But I can vet, the question though was whether Medicare or Medicaid would pay for it, and I'm not sure off the top of my head. I'll ask though.
Okay, yeah, I think that's because we don't want that to be a barrier for anybody, you know, in receiving that medication if they need that, and cost can be if it's prohibitive for them to be able to do that. I also heard Dr. Barnes mention that that you don't give an antibiotic for COVID. Did I hear that properly?
Yes, antibiotics will not help with COVID. COVID is a virus. It has a different treatment. Antibiotics are for bacteria. So unless they think that they have somehow also gotten a bacterial infection, antibiotics and steroids are not recommended. So that's something else that we've been emphasizing with healthcare providers, that some of the things that you would normally give to someone who comes in with, you know, what you think of as might be walking pneumonia or whatever off the top of your head wouldn't be something you should give and might even make things worse for COVID.
So that's steroid as well, because I have heard some people say.
That's right.
Okay, that's good information to know, because I have heard some people saying that their doctors were giving them a steroid early on for this. So that's, again, everybody, we should all be mindful of that. And it was mentioned that you could talk to the medical directors. So is that something that, how would that happen if my medical director in my facility was saying, no, we're not comfortable in giving this, I just don't know enough about it. We're not going to recommend any of these treatment options for anybody who lives here. What would happen as a family
I
member?
would ask the long-term care facility to contact the local health department and and then if they feel that they would like to have us speak to that medical director, because the local health departments are really the ones most closely working with the facilities. There's 1,500 facilities, you know, long-term care facilities in Illinois, and then we have 97 local health departments that are working with the ones in their jurisdiction. And so they would be the first point of contact, but not to delay very long, but they should reach out to the local health department. The local health department can get in touch with us
So as a
if
resident,
needed.
so as a resident in a facility or a family member of a resident in a facility, if they say, no, we're not comfortable in giving these treatment options, we don't know enough about it, so that's not something we're doing here, they could call the local health department themselves, the facility, and make them aware of the response from the facility. And
Yes, and the family members can call the local health department as well.
I think that sounds like a good, I'm trying to figure out how everybody on this call, if they are being told no, how that can turn into a yes for them so that they get the treatment that they want. So it feels like if you're told no, then to go to your local health department, call them. That should be a number that you could readily get. If not, you could also reach out to your ombudsman and they could help facilitate that for you by getting you that information. And to tell them that you want them to speak to the facility. And from there, if they don't listen to the local health department, then they can reach out to the state, to the IDPH infection prevention team, and they would be able to talk with that medical director to help share with them their vast amount of knowledge about these treatments so they can feel more comfortable in being able to offer it to the people who live in the facilities. Did we have any questions in the chat?
I'm not seeing any questions, Lee.
Okay.
Yeah, I don't see any either. I've been watching.
Okay, well, that's good. That means that we have a lot of information that we have been able to convey off to people in a succinct manner that people understand. If anybody would like to unmute their mic, if they have a question that they wanted to ask, or if they had an experience that they wanted to share, please do feel free to please do feel free to do that.
I Oh, sorry. I did want to mention that in the meantime, I was looking up, and Medicare does cover the monoclonal antibodies. They say you pay nothing for monoclonal antibody treatment during the COVID-19 public health emergency and for the rest of the calendar year in which the COVID-19 public health emergency ends, when you get it from a Medicare provider or supplier. So, and that is for monoclonal antibody treatments. And that goes back to 2020. I do not believe that has changed. So.
And what about Medicaid?
Well, this was for Medicare coverage and costs related to COVID-19 treatments. So I would imagine the centers did it a Medicare coverage. I'm not sure about the Medicaid piece, but I would think that most of the ones in long-term care would be more well, we'll see. I'll see if that also applies to Medicaid. I'd be surprised if it didn't, but it may not. But in any event, for sure, Medicare is covering it.
That's very good to know. Thank you so much for looking that up, so that can help people feel a little bit more at peace when pursuing this, because it's the last thing you want is be able to be hit with a big bill afterwards, after you receive the treatment. So thank you for looking that up. So with that, if anybody doesn't have any questions, I am feeling at this point then that we can go ahead and I will end the recording, but we will stay on to be able to, because sometimes people are much more comfortable post-recording, opening up their mics. And I am going to share a poll with everybody. If you could please go ahead and answer the poll for us, that would be very helpful. We would appreciate that. And at that point then I'm going to stop the recording.